Hi everyone, I'm Dr. Joel Aronowitz and welcome back to our channel. Today I have something a little bit different. This is a conversation from the exam room with a woman who's a forensic psychologist. It's a very interesting field. You may know something about it, maybe more about it than I do, but I thought it was interesting to have a chat with her about the aspects of forensic psychology that overlap with what goes on behind closed doors in an exam room. This is kind of a touchy subject, but it's something that both the providers in medicine, doctors, nurses, PAs, and actually anyone who finds himself in an exam room with a patient should be aware of and should be cognizant of the various issues, and as well as for patients. So I thought I would share this conversation with you. I hope you find it as interesting as I did. Let me know if you like this sort of content. If you have any questions or comments, please leave them below for me. Thanks.
Works anywhere within the legal system, applying psychological principles to try to answer legal questions.
So for example, I get a parking ticket and I say I really needed to park there because it makes me anxious to not have a parking spot, and you would come and defend me, or something more serious?
Well, potentially. I'm not sure that excuse is going to fly.
And I was telling you about a case that I actually testified in of a doctor who was doing funny stuff, recording patients in the exam room and then using their recordings for their own purposes. And so if you're a patient and how can you tell what should make you suspicious that there's something weird going on some non-professional level, sexual or some other, for lack of a better word, perverted, thing going on?
Well, that's the thing. You don't always know. You don't know. I've had cases with gynecologists that sexually touch their patients, anesthesiologists that sexually touch their patients. Just about any kind of physician can have some kind of issue. In this case, where you probably have a voyeur that's putting cameras in there, so you can't always tell. But I think the most important thing is what we see in terms of victim behaviors is that people don't tend to report this right away. They're afraid. And this is how physicians who do become sexually inappropriate with their patients, they're able to accomplish that because they're in a position of power and authority already. Mm-hmm. And so
I don't feel like power, but I understand what you mean.
Right. And so we're kind of brought up to not question and that's changing. It's certainly changing over the last 20, 30 years, but we're brought up not to question physicians, not to question people who have advanced medical degrees, and so people don't tend to come forward.
Well, if we've learned anything over the last 3 years, it's question those with advanced degrees. But so let me ask you this: is it always a male victimizing a female, or is it female, or the other way around, or?
Well, it's usually male. 95% of the time it's male. And in my experience, I haven't had any female physicians brought up in any kind of inappropriate sexual things, but it's males. And the reason for that is 95% males, because males have testosterone. And testosterone fuels sexual behavior.
Yeah.
But
women also have testosterone.
Very small amounts.
And women, you can size up the relative testosterone level of a group. Like if you work with 15 people and you have people rate them, their coworkers, the relative testosterone levels line up very, very well, actually. So it couldn't be just testosterone, but I hear what you're saying in terms of the sexual drive.
Exactly. And women do, we hear of women teachers and things like that. So women do, but they tend to do it for more emotional reasons rather than sexual.
So then if you're a woman and you're going to see the doctor and you're going to go see a male doctor and you're going to disrobe, or you're going to be in a position where you don't have all your clothes on, or, there's some intimate examination kind of thing going on, what should should you worry about that? And what are any triggers that you should take as indicators there's something else going on?
Well, I think number one, the most important thing is there always should be a female chaperone inside the room whenever you're disrobing to any degree.
Yeah, and I tell all the doctor trainees and colleagues, that is standard of care now, is if you're in the room alone with a patient, actually, could be a man or a woman, you shouldn't be alone. You should have a chaperone there for everybody's benefit.
Right, and I would also add, just based on my experience with the cases I've been involved with, that if, like, for instance, when you're in with a gynecologist, sometimes the gynecologist will be in front of you this way with a blanket or whatever kind of tissue paper, and then the chaperone will be behind you. I would say, oh, would you mind moving over there? And having the chaperone being able to actually physically put eyes on what is happening, because in some of the cases I've been involved with, it's been happening behind the curtain, so to speak, and there's other people in the room, which also make it more difficult to say, hey, this happened to me, and there are people around. And I think patients just have to be more proactive about it, and it's difficult. But I think if you at the beginning say, hey, oh, would you mind sitting over here? I don't mind if you're over here. Just something like that at the beginning, and make sure that the chaperone is watching everything that's taking place. And I think that's the best way to ensure that nothing is going to happen. But in terms of cameras, honestly, I don't know what you can do, because there's so many ways that you could put cameras in, and that's so rare. I think it's also important to realize that most of this stuff is very rare. The chances of it happening are very slim. So
yeah, that's a good point. In the case I was involved in, where there were cameras, it was obvious that the doctor was moving the patient around in such a way, and there were a lot of mirrors, that there was something organized about it. So a lot of our viewers, a lot of people that follow our channel, are doctors, they're nurses, they're PAs, they're people on their path, that career path, they're wannabes. What would you tell a young doctor or trainee about avoiding this problem? Because it's sort of thing that if you're accused of something, would be absolutely devastating, both personally and professionally. It'd be just professional destruction, and you want to protect yourself from that kind of accusation. What would you tell them? What kind of advice?
I think the best advice is to always have a chaperone in the room. That is the number one best advice. If you're rushing, if you're late, I understand, oh, I don't have time, or I've got the next patient to get to, or whatever. Do not let that person be in any kind of state of undress without a chaperone present, physically watching everything that you do. And I've been in situations where I've had to sign that I'm aware that a chaperone needs to be in the room and all that as a patient. So that's another way to protect yourself.
Just always have a chaperone and document that.
And I'm trying to think of anything else. I think just keep the professional boundaries. Otherwise, I think I always enjoy being in an office that's friendly and I feel at home. And but just watch your professional boundaries, and then also. Plastic surgeons are very good at kind of assessing somebody's psychology. I think they're better than a lot of physicians. But if you have someone that you can tell, has some psychological problems and is mainly seeking plastic surgery to fix themselves emotionally, then maybe that's a person that you need to be extra careful with.
Yeah, I think along those lines, I would say, I actually don't know any dirty jokes anymore, but I tell stupid dad jokes to lighten things up, like, what did the fish say when he swam into the cement wall dam, just dumb popsicle stick jokes if I need to lighten things up, but I never tell sexual jokes, and I don't make sexual remarks, and I try to not really flirt in that context, in the exam room, which is especially when you're younger and there's more sexual tension that goes on. I try to not, if I'm feeling like the patient is massaging my ego, so to speak, and I'm feeling good, or there's something sexual going on, it alerts me that, wait, something's wrong, because the patient shouldn't be making me feel good about myself, and I shouldn't, they shouldn't be making me be interested in me socially and that kind of thing. And so those sort of things, when you're getting some non-professional vibe, it's a good time to back up and take a deep breath and figure out what's going on, or step out of the room and let it deflate a little bit, because that happens especially to younger doctors. There's another non-sexual thing called Munchausen, which I'm sure you're well aware of, that young doctors see actually very frequently, because those patients those patients go to young doctors, and they kind of pump you up, and then all of it, and it's like, oh yeah, I'm the hero, and no, you're not the hero, you're just another doctor, and there's a reason, they're pumping you up. Well, that's very
And I'll just add quickly, along those lines, I think it's really important to, like you're saying, monitor your own feelings. If you're feeling sexual attraction towards your patient, then that's a major red flag. That's what they always taught us in grad school in psychology. Which will happen to you
if you're honest with yourself.
Always.
And it will happen to you.
As a psychologist, it happens too.
Yeah.
It happens in every professional relationship. There's nothing wrong with it. It's just a signal that you need to pay attention to.
You've got to manage it.
And then the other thing that I've seen, because I've seen more psychologists blow their career, because it's just what I do for a living, on sexual inappropriateness, is taking care of yourself emotionally, because it's your loneliness that's going to drop those boundaries. It's those loneliness needs that you're not paying attention of, not necessarily even the sexual ones, but it's the loneliness ones that, and like you're saying, the ego and feeding your ego, try to fill your loneliness that way.
Get a dog.
Yep, exactly.
You need
take
a friend,
care of yourself that
get
way.
a dog.
Take care of yourself that way, and you'll stay out of trouble too.
Yeah,
so.
And if you're like me, just deep down you're shallow, it's easier. Thank you so much for sharing all that.
And thank you for
what an interesting career.
Thank you.
If somebody wants to be a forensic psychologist, how would they go about that?
Well, you get a PhD, you can get a PsyD, which is a Doctor of Psychology. I've got a Doctor of Philosophy in Psychology. And you just go get experience in forensic psychology. So undergraduate, I worked at a variety of placements. I didn't do all forensic psychology. I worked at County USC. I worked at Long Beach VA Medical Center. I worked at a couple state hospitals. And then I specialized in forensic psychology in my pre-doctoral and then my postdoctoral work.
But important to start at your earliest stages, express that interest and seek that experience.
A little bit. I think it's always good, and I'm sure it's true in your training as well, you have to be a good generalist before you're a good specialist.
Yeah.
So the mistake I see a lot of forensic psychologists making is just doing only forensic, or only working with criminals, or only working at prisons. Well, you see the gamut. Like I saw conversion disorder, and now it's called functional neurological, something like that disorder, just the other day. It's the second one in my career. It's just, you see these rare things.
Like Heidi, like the story of Heidi, where she can't walk because there's something, is that a conversion disorder?
Right, yeah. That doesn't make sense neurologically, but you're having neurological
It's a good movie
symptoms.
if you want to see a conversion disorder, Heidi.
Mm-hmm.
Thank you very much.
Thank
I hope you all enjoyed that little
Thank
chat.
you.
It's something a little different that comes up in plastic surgery, and it really overlaps a lot.
Thank you.
Mm-hmm.